Great. I just wanted to thank everyone for coming today to our seminar series, where we're going to be discussing nurse practitioner regulatory assessment and transitioning from an on-site to a virtual format. I'm delighted to say we have three excellent speakers today that will be speaking to us about this particular topic and some of the issues and considerations from a usability and human factors perspective. Our first speaker is one of our alumni, Danica Tuden, and Danica is a quality assurance coordinator at the British Columbia College of Nurses and Midwives. Danica has been a registered nurse for over 30 years in settings such as acute care, community, telehealth, and health informatics. In 2017, Danica moved into a new career path, which involves the regulation of nurses and midwives at BCCNM. Her portfolio is within the quality assurance area, where she provides oversight of the registrant QA program operational processes, primarily within the nurse practitioner peer review and the administration of the controlled prescription pad program. Danica holds a Bachelor of Science in Nursing and in Health Information Science with a focus on human factors, usability, evaluation, and virtual care. I'm also would like to introduce Darlene Secong, who is a quality assurance consultant with the BC College of Nurses and Midwives and a registered psychiatric nurse with over 10 years of clinical experience in adult mental health and psychiatric emergency nursing. In 2009, Darlene transitioned to a career in health professional regulation with a focus on research, quality assurance, policy, and program development. Darlene has a bachelor's of psychiatric nursing from Cowalton Polytechnical University and a master's of public health from the University of British Columbia. Welcome, Darlene. And last but not least, Alison Wainwright is the director of the quality assurance program within the British Columbia College of Nurses and Midwives. Alison is a registered nurse with over 10 years of experience in health professional regulation with a focus on policy and research analysis, standards development, quality assurance, and continuing competence for nurses and midwives. Alison holds a Master's of Science in Children, Young People, and Family Wellbeing from Oxford Brookes University and is a fellow of the National Council of State Boards of Nursing Institute for Regulatory Excellence. And on that note, I will hand over the presentation to our speakers. Thank you for coming today. We really appreciate this.
Great, thank you for having us. Maybe we can move over to the next slide and I'll get us started here. So just to start off, we're coming to you from different areas of the Lower Mainland today, but would like to acknowledge with great respect that the BCCNM's office is located on the unceded territories of the Hunkaminam speaking peoples, the Musqueam and Tsleil-Waututh nations, and the Squamish-Sneecham speaking peoples, the Squamish Nation, whose historical relationships with the land continue to this day. I'm coming to you today from my home office, which is located on the territories of the Tawasit First Nation. We can move on to the next slide. So just a little bit of an intro about this project. So this work involved transitioning what was our nurse practitioner on-site peer review into a virtual format, and that started in the depths of the COVID-19 pandemic in September 2020. And as we started looking at what we might do to transition this assessment that was solely conducted in person, we recognized there were areas of the project that would require a human factors approach to ensure a successful outcome. And so, of course, we started looking into some of the background information and literature and really found also that there was nothing specific on the topic of using human factors or usability engineering methods in that health professions regulatory context or in that context of regulatory performance assessment. So that kind of spurred us to also write this up as a paper to highlight the importance of usability in a regulatory organization. And that article is published in the December 2023 edition of Computers Informatics Nursing. And we're gonna give you an overview of that pilot project today. Next slide, please. So just a little bit about BCCNM and what we do and the nurse practitioner profession in British Columbia. So BCCNM is one of the largest health professions regulators in Western Canada, where we regulate over 60,000 professionals. So that includes licensed practical nurses, nurse practitioners, who we're going to talk about today, registered midwives, registered nurses, and registered psychiatric nurses. So as a regulator, BCCNM has a number of different functions, but we establish the conditions and requirements for registration. monitor and enforce standards of practice and professional ethics, which also includes the quality assurance program, which we're part of. We also review education programs and some specific education courses, as well as run the inquiry, discipline, and monitoring functions to ensure safe practice. And our overall mandate is to protect the public. So all of those regulatory functions are conducted with keeping the public safe in mind. Can I get to, sorry, go back one there? There we go. So nurse practitioners, they're autonomous masters or doctorally prepared nursing professionals. They have a really broad scope of practice, and so they can do things like diagnose diseases and disorders. They can perform specific procedures. They can order and interpret test results, and they can also prescribe drugs, and that includes controlled drugs and substances. Next slide, please. So the nurse practitioner on-site peer review, how it came to be was the profession of nurse practitioners was introduced in British Columbia in 2005, and so as that was coming forward, there was a recognized need to develop a regulatory assessment that was able to measure whether this new profession was providing safe, competent, and ethical care. And so the nurse practitioner on-site peer review assessment was developed. It involves a critical review of documentation using specific chart review guidelines that are based on BCCNM scope of practice and entry-level competencies for nurse practitioners. And how it works is we have a group of experienced nurse practitioner assessors. They're contracted by BCCNM, and they would visit the NP's place of practice, and they would complete that chart review assessment. Usually by reviewing 10 randomly selected charts, we usually ask that 30 charts be provided. The assessor selects 10, and if there's controlled drugs and substances prescribing, they have to include 3 charts that include controlled drugs and substances. And those charts could be electronic medical records, they could be paper charts, or they can be a mix of both. Next slide. So once the assessor has gone to the place of practice, gone through the chart review guidelines, completed the review, they do a debrief with that nurse practitioner to look at the findings. They discuss what their strengths are, and as well as any opportunities for practice improvement, and they will discuss strategies together for how the NP can work to make changes or improve their practice in the areas identified. The assessor then completes and submits a report through our online platform. And then that report is available to both the nurse practitioner. It's also available to quality assurance program staff, and it can be reviewed by our quality assurance committee, who have responsibility for making the final decision about the outcome of the review.
Okay, so it's my turn now. This is Danica speaking. So the purpose of this project, so back in March 2020, the BCCNM's quality assurance program postponed the nurse practitioner on-site peer review for the remainder of the year in light of the social distancing measures instituted during the COVID-19 pandemic. With an uncertain timeline for returning to the on-site reviews, we decided to launch an assessment and pilot project exploring the feasibility of actually conducting in-person reviews using a virtual format instead. And we had to consider many factors that would actually affect the transition to virtual, particularly the technical. So that would be more of the hardware, software pieces, as well as other potential system components. The workflow, so that's more about how the user walks through the system or navigates the systems. And then, of course, the usability aspects, which I'll talk to more on the next slide. Okay, so in terms of the utility of cognitive and usability engineering methods, Kushner and Patel discussed these to ensure that health information systems can be used safely, effectively, efficiently, and enjoyably. We certainly want to ensure that the user experience is pleasant and not fraught with multiple clicks or system navigation issues that could be challenging. Excuse me. Although the work does not involve an actual health information system specifically that directs impact to patient care, for example, like an EMR, the same methods can be applied as they are all based on human-computer interaction with NP assessors using multiple information systems. So, for example, we have 3 different things to consider here. Online NP assessor-specific resources. 2 up. Online platform that the assessor uses to complete the report and that the NP can also access. Also, the electronic medical records. And what I was just discussing was the online NP assessor specific resources such as practice standards, scope of practice, and other various tools. Ultimately, how NP assessors use the technology can indirectly impact how they perform the review of an NP's documentation of patient care. So again, just to reiterate, usability engineering methods can be used in more than just health information systems because they certainly still can indirectly impact patient care and safety. Next slide, please. I think this is yours now, Darlene.
Thanks, Danica. So to inform our work, we utilize a scoping review methodology to broadly look at the literature on virtual assessment methods. We wanted to understand what were some of the benefits, as well as some of the limitations and the risks with this method. And we also wanted to look at examples on tools and specific innovations that we potentially leverage and apply to our program. So the literature that we found were mostly studies that involved medical students, nursing students, midwifery students, as well as healthcare providers in the clinical setting. There was really nothing specific to regulators and the work that they were doing. So we also looked at the websites of select regulatory bodies, both within BC and Canada, as well as internationally, for information on how they have transitioned their programs to an online or a virtual format. So an interesting finding was really a clear shift towards virtual and remote operations in lieu of the social distancing measures that were introduced during the COVID-19 pandemic. So this included a huge increase in the use of video conferencing technology, both to provide virtual care, as well as for schools and other healthcare organizations to continue to deliver services during the pandemic. Some of the benefits that were associated with virtual methods include, convenience and efficiency, and as well as improving accessibility and minimizing geographical barriers, particularly for rural and remote communities. Improved engagement was also noticed, particularly with some cohorts. It was particularly appealing to the younger generation. But there were also some concerns about potential reliability of virtual assessment methods. For example, one of the studies looked at video-based recordings for a peer assessment, and they found that you really need a copious amount of video recordings for it to be reliable. And so it became a balance, about your methodology, but also what is operationally feasible. And of course, you need dedicated resources and technology to implement the changes and to support a virtual transition. And then there are the concerns about data security and privacy. Next slide, please. And also in the fall of 2020, we embarked in a multi-pronged consultation process. We wanted to examine the feasibility of transitioning our program to a virtual format. And we really wanted to engage those who are going to be most affected by the changes, our NP assessors, the NPs. And we also wanted to consult with system partners and other organizations whose support and help was going to be instrumental to the success of the pilot project. So we conducted semi-structured interviews with key informants, including our NP assessors, NPs in leadership positions within the health authorities, as well as the Nursing Association of BC and PBC. And they work closely with NPs who are employed in the primary care network. And then we also consulted with the College of Physicians and Surgeons of BC and the College of Pharmacists of BC, who were at the time also exploring transitioning their programs to a virtual delivery format. And we also surveyed NPs, those who had either recently completed a review or who were selected for a review that year. So through our consultations, we're able to explore the NPs and our assessors' readiness and openness to engage in a virtual assessment method, their experience and comfort with using specific video conferencing platforms, as well as different electronic medical record systems and what was being used out there. From the health authority perspective, we were able to gauge their capacity to support this work, including their ability to provide our assessors with remote access to EMRs. And we found that there was really a huge variance between health authorities and their capacity to do this. Some had already essentially implemented remote operations, and so they already had established processes and dedicated teams that would support us, whereas others were still trying to figure their processes out along the way. And so by doing the consultations, it allowed us to refine our sampling approach, and we were able to narrow it down to 2 health authorities who were able to support us in this work, who had the capacity and the ability to do so, and also select NPs who were working in sites and facilities who could support a virtual assessment. And as a result, we were able to identify a cohort of 8 NPs and 5 assessors to participate in the pilot. Next slide, please. Okay, I think this is you again, Danica.
Yeah, yes, it is. Thanks, Darlene. Okay, so in terms of the virtual method, I'd like to give you a bit of an introduction into what we did. So the NP peer review in its virtual format involves establishing technology and a work area, the workstation area, that's required to correspond with some of the same components that are used within the on-site process. So of course, with that, a comprehensive orientation session for NP assessors was held, along with a number of resource materials. We identified 4 main components that we felt would ensure a successful transition. Definitely there was system things and then workflow things. So I'll kind of talk about a little bit of them here. For the first one, video conferencing platform. So this is used for the introductory meeting at the beginning of the day that Alison had mentioned previously, between the NP and the assessor, as well as the post-review discussion. Some of the tools used here are the screen sharing for looking at the report or potentially the EMR, and also the give control in case, for example, the NP wanted to share something that they had identified. These can be used so that there's good communication and actually some visual communication of some of the documents that were available. A process number 2, to facilitate remote access of the EMR. So this was a little bit challenging in some places, but as Darlene also mentioned, there were 2 health authorities that were ready. And over time, there have been more improvements in this process, although we still have sometimes challenges, and we'll talk about that a little bit later. For number 3, the NP assessor virtual workstation setup. So hardware and software for a useful, which is the ease of use of a system, and usable, which is alluding to the accuracy and information being up to date in that context of experience. We also needed to develop training materials, orientation, and technology supports. So usability testing was very important to integrate in all phases of the system development lifecycle, SDLC, to mitigate the risk for technology-induced error that was highlighted by some work that Baricki and Kushnerich did, as well as to ensure successful user adoption. And just to clarify, systems development lifecycle is an iterative process that includes project planning, analysis, design, implementation, and system support and maintenance. Next slide, please. Okay, so another area that we had to look at was the nurse practitioner assessor initial setup of workstation and technology. So we needed to consider the workflow, again, as I had mentioned earlier, in terms of navigating through multiple health information systems. They needed to have access to computers or computers and screens. And so usually what they end up doing is they use their own computers, and then we give them guidance on how to set this up. For example, they might have the EMR set up on one screen, the online tool that they use to complete the report and the assessment pieces on another screen, and then having WebEx underneath to use that when they do the morning phone call, a video conferencing session, and then at the end of the day when they do the post-review interview to discuss the report. So acknowledging that there are multiple actually, operating systems with specific logins, software applications, security firewalls, multi-factor authentication, and therefore a customized workflow was created and tested by QA program staff. Now, having said that, it was also realized that NP assessors, if they're using their own computers or they're using a work computer, for example, they will have existing logins and firewalls, et cetera, that we would probably need to look at carefully and develop a even further customized type of workflow for them to be able to do a review. We also created testing sessions for QA program staff to work with the NP and the NP assessor, as well as having our own IT support available for troubleshooting. For example, for the video conferencing testing, to go over some of the functionality items. Now, this was quite some time ago, and obviously people have become more and more adept to using video conferencing and their associated tools. So more of the sessions have been focused on the actual, what the day of the review looks like, and all of the components of the review and what to expect. Also, just to give you some extra information, we did consider clinical simulation as a usability testing method. However, it wasn't feasible as there were a lot of limitations in obtaining EMR access. So we couldn't get a robust simulation of the system. So it definitely was something that we had thought about because of privacy and all of the components related to accessing the EMR and associated systems, we decided not to go that route. Okay, next slide. All right, so we also looked at comparing the virtual method with the on-site method, and I do apologize that the font is a bit small here. This is actually a screenshot from the journal article, and it's on page 4 if you want to access it. I'm pretty sure it would be in the UVic database. I won't go over all of these points, but I would like to highlight a couple of interesting differences. So with the mode of communication, travel and hotel accommodations can be all over BC. So this nurse practitioner review is for all NPs all over BC. And you know how widely BC goes. There's Northern Health, Interior Health, the island. And so there's a number of different accommodation things we have to consider. So there's the flight, the car, ferry, and in some cases, the travel may be over a few days, depending on where it is. For example, in Northern Health, there's only actually one flight in and out per day. So we needed to ensure that our assessors had flexibility to stay longer. And of course, with the virtual review, we don't have to worry about that. The flexibility of time is much more robust, and we can actually not even worry about an NP assessor trying to catch a flight, or if there's any inclement weather, that's another consideration, as we've had to have in-person reviews canceled. So we are very cognizant of when we actually do these types of reviews, if they are in person. So that also gives us an added benefit that we can do virtual reviews all year round. Also, virtual reviews, they can do these in their home or office. There are some technical considerations, of course, like training and testing, as we've mentioned earlier. And of course, there is the remote use of the medical records, which does require a lot more steps and in the arrangements for this. And it can be, it's obviously different according to the site, whether it's a health authority, for example, there's one go-to person. If it's a private clinic, that can be another consideration. So there are different ways of going about accessing the remote EMR. Okay, I will hand it off back to you, Darlene. Next slide.
Thanks, Danica. So to evaluate the success of the pilot project, we obtained feedback from our NP assessors, some of the NPs, as well as QA program staff who were involved in the pilot. So we conducted key informant interviews, focus groups with our NP assessors to understand what their experience was with the pilot project and delivering the peer review in a virtual format. And then, we wanted to know the differences between doing the review virtually versus on site, and what were some of the challenges there. And then for the NPs, we wanted to get their perspective on what went well, what could be improved, and some things that we can consider for our program more broadly to continuously improve on. And QA program staff throughout the pilot project maintained documentation about some of the challenges that came up, as well as some of the quick wins. So this allowed us to shift and adapt our processes and make improvements along the way as needed. Next slide, please. Thank you. So some of the benefits that were found in virtual reviews is that, overall it was felt to be a positive experience and a transition went well. Our assessors really appreciated the flexibility of being able to do the reviews from their office or from their homes. And as Danica mentioned, there is, the minimized the time restraints associated with traveling to and from the clinics. And also one of the concerns that had originally been raised in our initial consultation was whether a virtual review would be able to deliver the same sort of impact in terms of being able to build a rapport and relationships with NPs. And some of our assessors were concerned that this would have a detrimental impact on that. And they found that actually it did not diminish their ability to build those meaningful relationships. So that was a great finding. And from the NPs themselves that were surveyed, they found that the virtual review was actually less stressful and less intimidating than an on-site review. Despite our best efforts to really message that our program is non-punitive, it is still quite a stressful experience for the NPs. And so they felt that not having someone there in their physical space was less stressful. And it was also caused less disruptions to their clinic operations. Oftentimes, these are very small, crowded spaces, busy clinics. So not having to accommodate an extra person in your physical working space was definitely a benefit. And overall, virtual reviews were perceived to be really equal to the on-site reviews in terms of the quality and efficiency and the time it took to complete the reviews. Next slide, please. So some of the barriers and the challenges, one of them is really around obtaining remote EMR access, and this continues to be a challenge to this day. As we mentioned earlier, it really relies on the health authorities' capacity and readiness to be able to do that. And having a dedicated IT person, both within the college and within the health authorities, was really instrumental in navigating accessibility issues ahead of time. What we also found was that the process, the requirements, the parameters around the access itself really was not standardized and varies between health authorities. So for some, we could get access for a whole week. For others, it was only the day of the review. There were sometimes training requirements that they wanted our assessors to complete. So it required a little bit of pathfinding for us to kind of navigate through all these different nuances and differences between the health authorities. In the initial phases, there was also a bit of resistance from some clinics who really did not understand our role as a regulator and that it is within our mandate to be accessing these records. There were some concerns about client confidentiality and privacy. And so, we had to be a bit proactive with our messaging in that regard, and highlighting that, we are still held to the same standards as publicly operated bodies, in terms of maintaining that data security. And of course, scheduling during the pandemic was extremely challenging. We had assessors as well as NPs who were sometimes redeployed to help with pandemic response. And of course, everyone was overworked and there's a lot of strain on the healthcare system at the time. And so our program staff really had to be flexible and accommodating with deferring or rescheduling or even sometimes canceling reviews. And as Danica mentioned earlier, a virtual format does require a lot of upfront work for our staff, not only in securing EMR access, but also the additional testing sessions with the NPs and the assessors to make sure that everything was working, appropriately before the review. So there was a lot of back and forthing, and it just placed overall a heavy administrative burden on our staff, and even more so than we had an idea that this would be the case through our consultations, but it proved even more so than we anticipated. Next slide. And that's over to you, Alison.
Thank you. So in terms of the pilot outcome, we completed 8 reviews in March and April of 2021, which was a huge success. And as mentioned, the results identify that, the feasibility of the virtual reviews is an ongoing approach, and also that the quality was comparable to the on-site method. So we made the decision to continue the implementation of virtual reviews for the remainder of the year. The pilot was successful, and we were still in the middle of 2021 was still quite in the middle of the pandemic. And so it didn't look like we were going to be moving back to on-site anytime. So we decided to continue, and we were able to complete an additional 16 reviews. So we actually ended up completing a total of 24 virtual reviews by the end of 2021. Next slide. And it's over to you, Danica.
Thank you. Thanks, Alison. So some of the post-pilot considerations, as there were only a small number of NP assessors, we said 5, oriented to conducting virtual reviews, further work was done to orient the remaining NP assessors. So we ended up creating a mentorship framework for NP assessors. And so that this was going to be now applicable to both review formats, so in person and virtually. And this would offer guidance on orientation and training to the other NP assessors. Resource documents were also developed for this. But just to give you some context, experienced NP assessors would use this framework in training our existing assessors who had not performed a virtual review, as well as providing mentorship to new assessors as they were hired. So this was actually helpful for some guiding documentation on kind of what things that the new assessors or the ones that hadn't done virtual reviews, to give some context and information on how this comes out. The EMR access continues to be a work in progress, as both of my colleagues have alluded to. Still some issues with IT and vendor support. At times, reviews did need to be canceled or rescheduled. This seems to have decreased quite a bit over the last couple of years, particularly in this year. Actually, we're moving along quite quickly with a lot of virtual reviews. There's only been, I believe, a couple that have been scheduled as in person. But, despite the travel accommodation costs being high, prior to the virtual, we have seen that the costs have reduced, and video conferencing testing sessions facilitating the EMR access and the associated training and troubleshooting can actually involve increased staff and NP assessor time. So even though the costs are higher with in-person reviews, there is still more time dedicated to and our staff doing more training and troubleshooting. And one thing I was going to just highlight earlier, we talked about the EMR access and differences in how health authorities or private clinics managed it. As Darlene said, there was a challenge in some offered only 1 day access, some offered more days, and that really affected our testing processes as well. As in some cases, they were actually time stamped, and as soon as the EMR was opened, say for example, the review was going to be on a Monday and the NP assessor tested it, everything was fine on Friday. There were times where on Monday there was no access, and that's just because there was a timestamp and it ended. And so that was where there were some instances where it was crucial to get in touch with IT and figure out like to get that access reinstated. So we've moved on from then and we've learned definitely. Next slide, please. Okay, a few other things here. Additional criteria are now included in the scheduling process. So for example, the type of records, is it an EMR, paper-based, or hybrid? Obviously, if it's paper or hybrid, then we still have to continue on with the on-site review. But also, as we talked about earlier, travel implications, and then public health orders, which that's sort of been a little bit better now that we haven't really had to deal with anything. We're quite far beyond the pandemic at this point. But there are times still where it may be appropriate to schedule an on-site review. So for example, sometimes an NP has had some issues with their documentation and require a follow-up because there's maybe enough there in their documentation that they need to work on, some areas of improvement. And so in some cases, it might be deemed a higher risk, and then continuous exploration of policy to implement a scalable and longitudinally focused model would be helpful. So there are still instances, as I mentioned, on where an in-person still might be more appropriate, but just thinking about last year, we had 72% of our reviews were actually virtual and 28% were in person. So that's quite a change over time. And I think one more slide. So in conclusion, the outcome of this pilot project indicates that with adequate consultation, planning, including the application of frameworks such as the systems development lifecycle, in-person regulatory assessments involving critical chart reviews can be conducted virtually and quite successfully. And just given that the COVID-19 pandemic actually seemed to trigger a lot more virtual types of care and other areas that could be done virtually. I mean, think about even online shopping. Like there's so many things that have changed. So more people this is more mainstream now for people. So it is getting easier. And of course, then the benefits of virtual reviews continue to outweigh the challenges because of some of these things we've already talked about. Usability testing is very key to the success of virtual reviews, as evidenced by the implementation of all of the testing sessions that we've done to our users. It's so important to make sure that any process that you develop actually gets tested, whatever that looks like. Now, the one area that I did mention was a little bit tricky with the EMR access, but that's something that we're still working with in terms of how long that access is available. Some NP assessors with doing virtual reviews prefer to start a few days earlier, particularly if they have a family and they just want to do a little bit of work in the evening, they might get started earlier. And then on the day of the actual review, they might just do the interview session and do a little bit more work and then come back and finish a little bit earlier, just so that they've got, because it is quite a long day for assessors. It's usually scheduled for 8 hours. Sometimes it takes 4 hours, sometimes longer, depending on kind of what comes up during the review. But definitely the usability piece is super important. And conducting reviews continues into 2024 and has become the primary review method, as I had mentioned about the percentages that we performed last year, comparing virtual to in-person. and is expected to be an ongoing component of our BCCNM's QA program. And I think that concludes our session. And so we'll open it up to discussion and questions.